drives clinical what dri what drives clinical practice and what drives that you pathologists, academic pathologists, community pathologists start to implement in your biomarker? Is it the guideline? Is it the voice of an opinion leader? And I learned over the past 10 years, and that's what I'm going to talk about, summarizing 10 years in 10 lessons, that actually what drives clinical practice is you personally being convinced about the utility of a biomarker. And TILs and PD-L1 are just examples. Basically, I have not a single conflict of interest, which is surprising to many, but as TILs are a community-derived biomarker, which is morphology, it belongs to the community. It's a socialist biomarker. It's free for all and useful for many. The TILs working group established the first guideline on TILs in breast cancer, and other guidelines are coming, as you will notice if you want to be part of this, in other tumor types in the next years. From the moment the TILs working published the guideline, there was a tremendous surge of TILs publication. Why? Because everybody started to use the same method. And also in other tumor types, replicating the method how to score TILs in breast cancer, scoring TILs in colorectal cancer, head and neck cancer, and in lung cancer also. And if you want to be part of a global community of pathologists working not for profit on a community-derived biomarker in all its aspects, guidelines, educational materials, development of prospective phase 3 clinical trials, AI, integration of AI in clinical trials, you just have to send me an email. The first lesson is what you see is all there is. And this is an important lesson which I always tell to residents in training. Morphology is still key to what pathologists do in our daily practice. We have been bombarded over the past 20, 30 years with ever-increasing complex genomic technologies, which basically, and let's face it, not all of us, even not I, understand the details of it. And the simple notion that pathologists are saying, just look through the microscope, is causing confusion in clinicians' minds, saying, how can you beat a genomic assay just by looking through the microscope? Well, let's see the evidence. So what are the TILs? Basically, the TILs are lymphocytes and plasma cells. Easy, by convention. So not neutrophils, not eosinophils, not macrophages, lymphocytes. Why? Not because there was a particular biology, but because it was easy for pathologists to see them. Okay, this is a case with high TILs, very easy. This is a case with no TILs. This is what we have been seeing for decades already. And the first report on TILs in breast cancer was in 1920 by Dr. McCarthy, pathologist at the Mayo Clinic. And interestingly, as an anecdote, 5 years ago, right before the pandemic, the Mayo Clinic invited me to go to the Mayo Clinic in Rochester to meet the grandson of Dr. McCarthy. And we were going to review together his study 100 years ago, where they published and he published this. Patients with glandular and local lymphocytic filtration lived 140% longer than patients without lymphocytic infiltration. This is brilliant. And again, a pathologist just looking through his microscope. Before the era of breast cancer subtypes, before the era of even vaccines, he showed already a patient with a high amount of TILs, they do actually pretty good. Lesson 2, we are doing nothing new. And I was raised very humbly. And this is also what I tell the residents, always build on what others have developed. And most of the science that we see today is built on previous work. So let's stay humble in life. What you see here, to the left, you see liver, and to the right, you see a metastasis. This is a liver metastasis, all right? What you don't see, and that's important for what's come next, is you don't see immune cells. Most liver metastases don't have immune cells, or very little of them. This case is the same case as the other one, but just a few micrometers next to the invasive metastasis. This is a portal tract full with lymphocytes. So if you would do a genomic assay, you would capture these immune cells. So your genomic assay would say immune-enriched phenotype. And we as pathologists, we say no TILs. And then you get comments from the reviewer and the editor of journal saying, why is this discrepancy? Can you explain? Are you really sure about your result? Aiming to the pathologist. Well, actually, it's a genomic assay who is not measuring the immune cells as with the invasive cancer. This is another case, a skin metastasis, and we are pathologists. So have a look. You see the tumor cells, you don't see immune cells, and there is another cell type that is not available or seeable in this biopsy. These are fibroblasts. Okay, remember this. Lesson 3. Immune cells can be present next to the cancer. So whenever you do a genomic analysis based on T-cell repertoires, T-cell genomic signatures, interferon signatures, etc., the CD8 signatures, whatever, always have a pathologist look at the slide because you may be having false positive genomic immune-enriched tumors. You can't imagine how many manuscripts I get to see where it's clearly from the start evident that no pathologist has looked at the slides. And when there are no fibroblasts, there are no TILs. And this is an important lesson because where do we don't see fibroblasts? Mostly liver, skin, bone marrow, and brain. No fibroblast, no TILs. And who are the sites who are resistant to immunotherapy? Bone marrow, skin, liver, and brain. So morphology is complementary to all other assays and can inform treatment responses. Let's have a look at this. Considering the notion that you need fibroblasts to get immune cells in your tumor, so without fibroblasts, you never have immune cells because the immune cells need the fibroblasts to stick on and get into the cancer. If your clinician asks you where should you stay for PD-L1, if you have a patient that has a liver metastasis, a bone metastasis, you have the primary tumor, and you have a brain metastasis, which biopsy should you stay for PD-L1? Should you do it according to the genomic narrative, where you have to test the metastasis because that's killing the patient, right? Which is true for a genomic alteration like BRAF, EGFR, KRAS, etc. Is this also true for the immune system? Let's have a look. This is a phase 2 study partnered with Merck at the time, in which we analyzed in metastatic triple-negative breast cancer where they had metastasis biopsies, where don't we see immune cells? So we see immune cells in the lymph node, of course. We see immune cells in the liver, in the lung, and in the primary tumor. And all the other metastatic sites, the immune cells go down. So the metastatic environment, and this is the same for every solid tumor type. You see this in lung, you see this in melanoma, you see this in colorectal cancer, you see this in all types of solid metastasis. The metastatic environment is an immune-deprived environment. And why is this important? Because all PD-L1 assays rely on immune cells in breast cancer. Because a PD-L1 assay that strongly stains PD-L1 on the cancer cells is extremely rare. So PD-L1 reactivity, CPS, in triple-negative breast cancer is driven by immune cells. Lesson 4. Now you have 10 lessons. If possible, do not stain for PD-L1 in liver, skin, brain, or bone metastasis. Why? Because you don't have immune cells, because you don't have fibroblasts. Consider the primary. This is how the immune system works, and this is also why immunotherapy is not targeted therapy. Targeted therapy means you target the alteration that drives the growth of the cancer cells, like a BRAF mutation or KRAS. So you target the drug to the BRAF, to the driver. The immune system works different. The primary tumor generates a systemic immune response, and this protects you like a vaccine for many years after. And remember that in those phase 3 trials, from all the registration trials for immunotherapy, many patients, in some trials even the majority, have been stained in the primary tumor for PD-L1. So PD-L1 positive primary tumors respond to immunotherapy even when they develop metastasis many years later. where they get immunotherapy. The clinical guidelines. As I told you, in the early days, I thought it's in the clinical guidelines, so people will implement it. It didn't happen. Why not? We will see this in a minute. You have St. Gallen suggesting we want the TILs. ESMO suggested TILs are an important prognostic variable and predictive variable, later confirmed again. None of these guidelines explicitly said you have to report the TILs in your report. But they don't do this either for vessel invasion or grade. So the notion, the simple notion that they didn't mention it specifically, you have to put it in the report, was for pathologists. Some pathologists say, I don't add it in my report. While other pathologists looking at the same text said, I'm going to start to report it. And this is the real world evidence in the psychology about implementing a biomarker. It's not a guideline, it's about a pathologist interpreting a certain text in a particular document. What drives clinicians to give treatment to a patient? It's stage, tumor bulk. We did a very simple study. The best studies are the easiest one that you can explain at home to your children. This is a study. We collected 9 phase 3 trials. We scored the TILs. Collected 5 pathologists. We gave the slides to 5 pathologists. Didn't do a concordance analysis. Just say you score 1,000 cases, you score 1,000 cases, etc. Collected the TIL data. Triple negative breast cancer, advanced, local setting, so not metastatic. All treated with chemotherapy. To make a long story short, just look, forget the graph because it's a bit too much colors. Look to the left. Stage 1. What is stage 1? Tumor size up to 2 centimeters, lymph node negative. High TILs, 96% overall survival. Nothing new. Stage 2. What is stage 2? Stage 2 is 2 centimeters to 5 centimeters. Can be lymph node positive, grade 3. High TILs have a better outcome than a stage 1 with low TILs. So the immune system in triple negative breast cancer, and it's the same in HER2 positive disease, can up or downgrade stage. And which other biomarker does the same in luminal breast cancer? It's not the TILs. It's histological grade. Does exactly the same in luminal disease as the TILs do in triple negative and HER2 positive disease. Importantly, in this study, grade was not a prognostic variable. We did an additional study looking at the natural history. And this is the advantage of the TILs working group. Since we have so many partners, it's relatively easy. It's a lot of work to collect large data sets. We found a data set of patients who always get chemotherapy everywhere in the world. Patients triple negative, the young ones, younger than 40 years old. T1, T2, T3. To make a long story short, untreated, not a single droplet of chemotherapy. Only in the Netherlands we could do this. High TILs, 15 years overall survival without chemotherapy in triple negative patients younger than 40 years old. Only 2% develop distant metastasis. All these patients nowadays get chemotherapy. Dose dense, killing sometimes the patients. We went even further, thinking about what is driving the clinician's attitude toward biomarker, and that is changing his attitude. If you have a stage 3 with high TILs, clinicians say, I will give chemo anyway, I don't need the TILs. If you have a stage 1, that's where the question comes. We did an additional study, again, in the Netherlands. Simple study, 1,000 patients, 10 years follow-up, no chemotherapy, not a droplet, PT1C, high TILs, 98% 5 years outcome. Remember, PT1C, no TILs, relatively recent population, high TILs, excellent outcome. And again, no chemotherapy, nothing. Can you imagine? No chemo. This was still not enough for the clinical community because they were selling the Netherlands, they were all hyper progressive, selection bias. You already selected patients who were doing excellent anyway. So, no, that's convincing. So, what we did with the working group again, took data sets from Japan, Korea, South Korea, not the North, Europe, and the US. Same story, 2,000 patients, no chemotherapy. Took a while to collect the data. Took even longer to get the legal contracts ready, but we did it. Now we're going to perform large-scale AI projects on this data set. To make a long story short, look, PT1C as an example, to your bottom right, high TILs, 96% 5 years overall survival with data sets from different countries. So all this data combined suggests at least that early stage triple negative breast cancer with high TILs assessed by you just using a microscope can identify patients who are having probably not so much benefit from chemotherapy. Am I saying that we should not give chemotherapy to these patients? No, of course not. I'm just saying it's useful information to know. And that's an important notion on the TILs. Lesson 5. Everything what I told you, if you combine it, it's level 1B evidence. And in the old guidelines from Daniel Hayes, it is mentioned if you have level 1, this is practice changing. Well, it doesn't. Because again, what changes clinical practice is a personal conviction about, is it useful for me, for my patient sitting in front of me? And when you talk to clinicians about why don't you use the TILs despite this, and you just see a fraction with Mount Everest of data, they say you need prospective randomized data. And I've been discussing with them for 10 years. And the question is, really? Do we really need prospective randomized data for a prognostic variable? Let's do a quiz. How many prognostic variables that you use in your daily practice, that you probably have reported still today, as I did, have the highest level of evidence, meaning prospective randomized designs? So great, for example, lymphovascular tumor invasion, mitotic activity, these type of things. All of them, none, or just one? Okay, give you 2 seconds more. Who thinks all of them? None? The answer is just one. Which one? Histological grade? No. Lymphovascular tumor invasion, level of evidence 3. We all reported. Mitotic activity? No. Gene expression profiles. And which one? Just 2. MammaPrint, Oncotype. EndoPredict? Nope. Breast cancer index? Nope. Procinia? Nope. Do we all use these prognostic variables? Yes, we do. No prospective randomized data. Tell this to clinicians, they have no clue that it's not the highest level of evidence. And I'm not saying it's wrong to use them. I'm just saying they put the bar, and we as pathologists also, extremely high for a community-derived biomarker despite the amount of evidence. Yet for other, mostly industry-derived biomarker, psychology of daily practice, we put the bar very much lower. And here comes society with all its force and human nature. And I told you again, it's implementing a biomarker coming from us is a psychological exercise. Let's see about treatments. Clinicians always claim, yeah, we need evidence-based data, randomized, etc., to implement treatments. Let's have a look if this is really the case. The chemo benefit in stage 1. In T1, this is a meta-analysis. T1A is non-existing. In T1B, it's non-existing. In T1C, only 3%. Chemotherapy benefit in stage 1. I showed you, remember PT1C, PT1A, PT1B, high TILs. Enormously beneficial outcome without chemotherapy. This is all randomized. This is not randomized data. This is all retrospective analysis. There is no prospective randomized data on how to treat early stage triple negative. Doesn't exist. All the treatments are based on retrospective analysis, and look at what the guidelines say. ESMO says if you have T1B, you give chemo. If you have an oncologist who reads NCCN, they say maybe, but if you live in the Netherlands, no chemo. Look for T1A. If you have breast cancer, and some of you probably have had or will get, depending on your clinician's attitude towards a guideline, you will get or you will not get chemotherapy. And remember the PT1C, all guidelines will recommend chemotherapy without prospective randomized data. This is a psychology about the clinician willing to give something instead of de-escalating a treatment. Psychology. It's easier to put something on the pile than to take something out of the pile. It's like buying a book. I have hundreds of books at home which I never read, and I always buy more. Human nature. Immunotherapy and TILs. And then we start to combine all these concepts which I just presented. My favorite trial, Keynote 119, metastatic triple-negative breast cancer. You give pembro, one arm, you give chemotherapy, the other arm, no combination, and you look at outcome. Was a negative trial using PD-L1. We looked at the TILs. Again, just looking through the microscope. I received a slide box at home, just put it on my microscope, scored the TILs, sent the data back in 2017. 2019 presented. What do you see? The blue line, high TILs, well, more than 5%. The gray line, no TILs, and in the middle one, chemo. TILs predict benefit, overall survival benefit, if you only give immunotherapy in the advanced setting. Nowadays, all patients get combination, right? Chemo plus pembro. If you have high TILs, you do excellent. Hazard ratio similar as in the Keynote 355. The Impasumab 30, atezol, same concept, metastatic triple-negative breast cancer. Positive trial was a negative trial in Impasumab 131. The same design, just the chemo arms were a bit different. The blue line, high TILs, 10% in this case. The red line, lower TILs. Survival benefit. So two prospective, retrospective analysis in phase 3 clinical trials showing exactly the same. TILs predict benefit. Remember, immunotherapy is not targeted treatment. Immunotherapy doesn't kill the cancer cells. Immunotherapy triggers the immune system, and the immune cells kill the cancer cells. And that's why the immune system is predictive. That's why PD-L1 as such is a bad biomarker. It's a good target for drugs because it really works. But as a biomarker, it's not suboptimal because it's not targeted treatment. What drives response are the immune cells, and the immune cells are the TILs. Let's look at this case. Remember, 2 phase 3 trials, and there are several other phase 3s and phase 2 showing exactly the same thing. High TILs, you see the dots in triple-negative breast cancer. This case was negative with the SP142 assay, but has many TILs, as you can see. This is my other favorite slide. Modern Pathology, one of our key journals, comparing LDTs, combined diagnostics for PD-L1, with reference materials in which you know exactly how many PD-L1 molecules there are. What does it show? All assays, LDTs with combined diagnostics measure more or less the same thing. So their sensitivity is more or less equal. This means in practical terms, it's equally brown for all of them. And the patterns are the same, except one, the SP142, which you see over there at the top. What does this mean? This means if your case is SP142 negative, it can be positive with one of the other assays. That's what it means. And if it's positive with SP142, it has to be positive with the other ones. That's the lesson. This case, remember, daily practice case, SP142 negative, many TILs. In the classical dogmatic sense, if we follow the narrative of industry, this case, patients should not get immunotherapy. Remember the data that I showed you? Confirmed several times back again. Remember the sensitivity analysis. What would you do as a clinician? Asking them. Nothing? Follow dogmatically the narrative of combined diagnostic. Call your pathologist, call us to say it has to be positive, just make it positive. Remember the cutoff was just 1%. Or you call your pathologist to ask him, reconsider your assay. The right answer is 3. See what you see. Morphology, again, a microscope, no genomics, no AI. We can talk about AI later if you want. To the left, triple-negative breast cancer, high TILs, you see the dots. Okay. In the middle, CD8. High CD8, high TILs, high TILs, high CD8. You see in the literature some meta-analysis with thousands of patients in all tumor types showing consistently over and over again CD8 predicts benefit immunotherapy, CD8 or the TILs. To the right, you see PD-L1. What do you see with PD-L1? You are a pathologist. Have a close look. Not all immune cells stay for PD-L1. Which cell type stands for PD-L1? Mostly the macrophages. So you always have more TILs than PD-L1, and that's important. Why? For the following. High TILs, high PD-L1, yes. So if you have a case like the case I presented to you, which has high TILs, that's a quality control measure for your PD-L1 assay because your PD-L1 assay has to be positive. If you have high TILs, you probably have a higher amount of macrophages, who most of them will stay for PD-L1. PD-L1 negative, no TILs. No, that's not true. They can still have this, as I showed you, and respond to immunotherapy. You will see trials being presented this year in so-called PD-L1 negative tumors miraculously responding to immunotherapy. And I always tell those vendors, those pharma companies, just score the TILs. We will see why. And they refuse, most of them. Still, we'll see. Furthermore, CPS versus TILs, that's what we do in metastatic triple-negative breast cancer. What's the real impact in daily practice of CPS? That's this. This is a negative case, but you are a pathologist. What do you see? Plenty of immune cells. It's not uncommon in our daily practice to see a case which is a high TILs and low PD-L1, or even negative, with a score less than 10. These patients should benefit from therapy even if the CPS is less than 10. Just between us, it's remarkable, I believe, that pharma still sticks dogmatically to PD-L1. And I recommend you to read the book of Barbara Tuchman, The March of Folly. And she describes historical cases from the Vietnam War to the Trojan War, to the selection of popes in the medieval age, where the humanity has been very successful in shooting themselves in the feet and taking decisions contrary to their own interests. It's like PD-L1. We continue to use PD-L1, even if all of us know that it's by far a suboptimal biomarker. So, high TILs predict benefit in several phase 3 trials. I could have shown you more and convinced you more and show you curves, etc. High TILs, high PD-L1, yes. PD-L1 negative, no TILs. No. You can have a CPS less than 10 with high TILs and still respond to immunotherapy. That's what the data shows. PD-L1 negative tumors can still have TILs and respond to immunotherapy. What about the other way around? No TILs, PD-L1 positive. Does it exist? Yes, it does. This study, the 7FL study, just published a few months ago, high-risk luminal disease, neoadjuvant immunotherapy plus chemotherapy versus chemotherapy alone. What do you see? We don't have outcome data yet. The more TILs you have, the higher the PCR rate. Okay. In this study, there was a subset of patients who were TILs negative and PD-L1 positive, responding to immunotherapy. To the residents in training in the audience, how do you explain that TILs negative, PD-L1 positive also respond to immunotherapy? I give you 5 seconds to think about it. Okay? Macrophages. And where do you find macrophages when there are no TILs? In TLS, tertiary lymphoid structures. There is an emerging amount of data suggesting that tertiary lymphoid structures also predict benefit to immunotherapy for a variety of reasons that we can discuss later. And the germinal center contains macrophages who stay for PD-L1. That's the reason. So PD-L1 and TILs are the yin and the yang. And we have said this for years already, in 2020, saying if you look at PD-L1, look at TILs and vice versa. This was interpreted by industry at the time as a kind of Trojan horse. PD-L1 was being used by many pathologists. And yes, Roberto, you want to get the TILs in daily practice, so you link it to PD-L1. No, read the manuscript. It's all based on evidence and common sense and pragmatism. The limits of my language meets the limits of my world. My third best quote that I always use in my lectures: if we don't understand what we are seeing, TILs, PD-L1, and this applies to everything what we do, it's very difficult to discuss with clinicians. Be pragmatic in your judgment of the evidence, even knowing that there is no yet prospective randomized data on TILs as a prognostic or predictive biomarker. The evidence is overwhelming that it may be already useful today as histological grade, as lymphovascular tumor invasion, as mitotic activity, as many other things. And I will start to introduce this notion of clinical usability. Why? Because we have analytical validity, we have clinical validity, we have clinical utility, and that's it. And the narrative with clinicians is you need to have clinical utility for every single prognostic and predictive biomarker usable in daily practice. What does this mean? Is that the academic community will never be able to change clinical practice. Why? Because you need pharma who have deep pockets to develop those prospective worldwide trials to get this level 1 prospective evidence. So this means that prognostic variables, such as the TILs, just as others, developed by community, will need common sense and pragmatism by us to consider their usability in daily practice. Lesson 8, building on this notion of clinical usability. Immune erythrocyte biomarkers that have been validated in prospective, retrospective settings. So far for triple negative, nearly 25,000 patients consistently showing the same thing. Or pooled analysis, meta-analysis, measure the same biological mechanism, can be used interchangeably without a prospective phase 3 trial validation. That's what I think. Why? Because in certain countries, let's forget the so-called developed world where most of us live in, India, Bangladesh, Cambodia, Colombia, Argentina, some parts of Europe even. A PD-L1 assay can be very expensive and unaffordable. Did you know that some labs in Latin America send their paraffin blood to the United States for a PD-L1 stain because that's cheaper than implementing the PD-L1 stain in their own country? And imagine if you have a patient in a country in South America who has high TILs, triple negative. Why would not the clinician consider that patient for immunotherapy based on all these prospective, retrospective analysis of phase 3 trials? Why not? And I agree that for predictive biomarkers, you may be willing to be very rigid. But sometimes I think in some parts of the world we are too rigid. If we would use the criteria you need prospective randomized data, we should stop grading luminal breast cancer. And we should do a genomic profile on all cases. We should stop doing lymphovascular tumor invasion. We should stop scoring mitotic activity and only do oncotype or MammaPrint. If we are consistent, this would be ridiculous, right? Okay. Psychology of clinics. Adding is favored over subtracting in problem solving. We always add more than we want to subtract. Nearly done, 10 minutes. Let me present you Erwin. Erwin is a 40-year-old, a bit more medical doctor who contacted me. End of 2023, her husband Adam and her 2 beautiful children. She had breast cancer, triple negative breast cancer with medullary features. And the report of the pathologist, maybe some of you in the audience mentioned a lot of TILs. Full. PD-L1 of 30, remember. She has a tumor size of 2.4 centimeters, lymph node negative. 2.4 centimeters, triple negative, lymph node negative. Stage 2. And for stage 2, currently the Keynote 522 regimen. What does it mean? Neoadjuvant chemotherapy plus immunotherapy, surgery, and then you give immunotherapy for 6 months. 1 year immunotherapy, 5 different chemotherapy schemes. The pathologist said a ton of TILs, and she wondered, what does it mean? And she started to review the manuscripts of the working group, and she contacted 4 pathologists, again the real world, to find one willing to score the TILs according to the guidelines. 80 to 85% of TILs. Okay. How did we call these tumors 15 years ago, for those old enough? We call these tumors medullary breast cancer in the old days. And what was the guideline 15 years ago for medullary breast cancer? No chemotherapy. And in 2019, at the WHO IARC Blue Book meeting, we decided, based on a lot of evidence, to say this is triple negative with medullary features. And what do clinicians read? Triple negative. So these patients all over the world get 1 year of immunotherapy and 6 months of chemotherapy. Well, just 15 years ago, we would have said surgery, maybe radiotherapy, and that's it. Illustrating how important it is that pathologists name their cancers. So she started to discuss, based on all the evidence that I presented to you, to de-escalate her treatment. And her oncologist said, no, because we have to rigidly follow the Keynote 522 trial. So she started surgery. Chemotherapy plus immunotherapy, 6 months. She had surgery in August, mid-August 2023, a complete pathological complete remission. So the universal response to her was, you are handling the treatment well because you had a complete pathological remission. So why should you stop your treatment? The reason of the clinician. Remember, the Keynote 522 design is complemented with 6 months additional immunotherapy after surgery, irrespective of your response. What data do we have on this? Published last year. If you have a PCR, the added value of pembro, just look at the curves, is actually negligible. But this patient, because the overall survival, the primary endpoint of Keynote 522 showed a survival benefit of 3 to 4%, nothing more. For the whole group, they did a subgroup now with PCR, no benefit. Yet, standard treatment for every single patient, stage 2, even with PCR, is 1 year immunotherapy. Illustrating the importance of pathologists at multidisciplinary meetings, most of them were relatively passive, just saying what we have seen. If you would be at the conference with all the data that I presented to you, and you would see a patient being discussed 2.1 centimeters, high TILs, we're going to give these patients 1 year of immunotherapy, even with a PCR. What would you tell the patient and your colleagues? This, I'm going to quote it literally. The clinician said, you're doing excellent. This is interpretation of the patient. Handling it well included loss of thyroid function, fatigue, dehydration, confusion, nausea, explosive diarrhea, severe thrush, sleep disruption, night sweats, hair loss, scalp tenderness, bone pain, joint pain, inability to work, drive, loss of confidence, etc., etc., etc. She was doing excellent according to the opinion of the clinician. This is the real life psychology. Clinician going to say, and now I'm going to give you 6 months additional immunotherapy. More. And her tumor has vanished. And she has 85% of TILs. Remember that study that I showed you? 15 years survival. If you do nothing, 2% benefit. She was going to get 1 year immunotherapy. She decided to stop, which in the United States is heroic. Here in Europe, we have this social security system. United States is heroic. Because if she would get a recurrence, all immune insurances would back off. And if you want to know more about this case with all its details, have a look at this manuscript. It's open access, published in GCO just last year. Lesson 9. Can you define the risk of recurrence without knowing what it is? You can't. You can't, basically. And I'm more assertive on this than I was 5 years ago. It's like determining treatments with luminal breast cancer without knowing on histological grade. You can't do this. And the TILs is just a biomarker. If you want to measure the immune system with the genomic assay, go ahead. But you need to know on the immune system in triple negative and HER2 positive disease. If you invite me next year, you will see a lot of data on this. In conclusion, The risk of recurrence is a continuum of context. This is the thing, continuum of context between the adjuvant and the neoadjuvant setting. The trials are categorized boxes, but we know that patients and outcome is a continuous thing. And you can't know this risk of recurrence without knowing the immune system. Can you define a clinically high-risk patient without knowing the TILs? No, you can't, but the TILs can help you. And I'm not saying you should not give chemotherapy, but it's very informative to a clinician. It will give information to the clinician the odds of recurrence to her patient, and then he or she decides in partnership with the patient what to do. Should we formally finally start to report this and to report? Many countries do, even without national guidelines. Many countries still don't, and that's fine. The TILs are not a hype, that's important. So I'm not selling you something, I want you to be convinced. And if you're not convinced, that's fine. Some pathologists, they do not implement the TILs because they say my oncologist doesn't request it. That's fine, why should we do it? Others say they just do it. They implement it in national guidelines or even in their own setting. Community pathologists calling the TILs because they know the literature and they say, I'm going to tell my clinician it's important, whether he wants or she wants to know it or not. Other pathologists are more careful to say, just wait for guidelines. And guidelines work as human nature works. You have to have convinced people who sit there and say, I want the TILs as part of the guidelines. And there's a fourth animal category, which I call the no category, but I always say no. And interestingly, I will not talk much about it. There are several prospective trials ongoing, which include local testing, and that local testing is driving extensively in those countries TIL implementation in daily practice. Final result then. We are good in producing academic output. Very good. We publish and we publish and we publish. We are not good in changing clinical practice because we put the bar too high, I believe. And we need to be more pragmatic with a lot of evidence and patient need. Imagine if we would have had this rigid criteria of prospective randomized data for historical grade, we would not score great in daily practice. Ian Ellis and his method. We should build a statue for him. Well, we wouldn't have used it if we would apply the same rigid criteria as people are using now for the TILs. If you want to be trained on TILs, the FDA has developed a very TIL course. You get CME credits, the only biomarker-driven course developed by the FDA for a variety of reasons. You can ask me about it. You get a certificate, and if you want to know more about the TILs, you can go to the TILs website. It's all you need to know. It's a voluntary activity. We don't have a lot of money. It's every year a search for funding to get this, to keep this running, but it's a community-based effort just for you. Thank you very much for all your attention. 45 minutes exactly. Oof. Thank you very much. I hope it was useful. Basta.
Thank you very much. This is great. So there are several